Welcome to Orthopedic Grand Rounds at Harborview. Today the topic is ankle arthritis, and Grand Rounds they are sponsored by the Sigvard Hansen Foot and Ankle Institute at Harborview, and we're fortunate to have the namesake of the institute here to lead it off. We're going to start today not with the standard epidemiology and prevalence issues, but we're going to go right into the meat of the matter. Dr. Hansen is going to talk about his experience with ankle replacements. Dr. Hansen?
I think we all know that for about 35 years now, we've been very successfully doing joint replacements, starting first in the hip and then in the knee. And all this was facilitated a bit by the fact that we started using prophylactic antibiotics about 35 years ago in surgery and doing it successfully. We've had antibiotics, of course, since about the time of the Second World War, but using them to protect from infection during surgery is only about 35 years old. The thing was, even at that early time, people started to try to replace the ankle, but it didn't work very well at all. And the problem is that the ankle is a much more complex joint than the knee, which is basically a hinge, and the hip, which is kind of a ball and socket. The ankle, as we know it, is really only half of a much more complex joint, which is a universal joint. The ankle joint works together with the subtalar joint, which is just below it in the foot, as a universal joint, and the subtalar joint shape is too complex to have had anybody successfully made an artificial joint. But it allows the foot to be somewhat flexible underneath the ankle, and so the problem of replacing the ankle joint is that it's really only replacing part of the joint, and it can't be made stable by just making the ankle joint stable. You have to make sure that the foot below it is stable and in alignment, which makes it quite complex. But for about 10 years now, we've had a reasonably successful ankle joint replacement. Most ankle joint arthritis is post-traumatic, and trauma is the most common in the young patients. But many patients present for their treatment at around 35 plus or minus 10 years of age. Now, this is a lot younger than you would normally like to do a joint replacement, and hips and knees are the same way. They work much better in older people who have less high-impact activity. But most of the knee and hip arthritis develops more often in later ages. It's a degenerative problem frequently, or it seems to be a degenerative problem, and most people that need replacements in those joints are indeed older. But the ankle is not susceptible so much to degenerative arthritis, but only gets arthritic in the face of trauma, almost only, or in the face of severe inflammatory arthritis like rheumatoid arthritis and its similar diseases. Now, the marginal group for this joint replacement then would be about roughly 45 to 60 years of age. And these are fairly common ages in my practice with foot and ankle. For instance, this lady who's 59 has post-traumatic arthrosis for 20 years. This is another interesting thing, is that the ankle, even when it's injured, it may take a long time from the point of injury until the arthritis develops. But sometimes, even that, because the injury may occur in the teens or 20s, you're still at a fairly young age when you come to the point of needing an ankle joint replacement. This patient has arthritis in both the ankle and the subtalar joint, which is another complex thing which we'll talk about as we get into details later. Like most joint replacement surgery though, as we've already said, total ankle joint replacement is best suited for these older patients with arthritis in a single joint, without surrounding soft tissue problems and in good alignment with a stable foot below. Unfortunately, these cases are relatively rare, particularly in my practice. We don't get to cherry pick and just take the nice easy ones because somebody has to take care of everybody else. Pure osteoarthritis, again, as I've already said, is almost non-existent in the ankle. Now clearly then, with the ankle, other approaches like bracing, debridement, osteotomy, muscle balancing, osteochondral grafts, any procedures that don't burn bridges, which would, by that I mean fusing the joint or replacing it, should be utilized in these younger patients whenever it'll be effective. For example, here we have a 29-year-old white female who is seen in consultation. You can see, if you're a little bit knowledgeable about ankles, that it's tilted. The foot is tilted out to the side. It's healed up from a very bad fracture just above the ankle. The joint space is there, but she's 29 years old. She's not a good candidate to have the ankle replaced. This, for example, is the one we would try to get the hardware out, get the ankle tilted back straight, and try to preserve it for a while. In spite of all these things that I've mentioned, many patients have to be treated even though all the available effective procedures are relatively contraindicated. For example, we may have a 25-year-old patient with a talus fracture and post-traumatic arthritis in both the subtalar and the ankle joints, and her options are really to be crippled, to have an amputation, or to do one of these contraindicated procedures, which would be to fuse one joint and replace the other. You can't just say that you're not a good candidate, we can't treat you. Now, fortunately, a number of the commonly believed principles in the joints are thankfully myths. The salvage of a failed arthroplasty can be done only by complex bone block fusion. That's not true. A fusion cannot be taken down and a total ankle replacement done later. That's one of the commonly held principles, but that's not true either. An ankle replacement or an ankle fusion, if done correctly, leaving the bone stock, can have a total ankle later, and I'll show you why that's important in a bit. They also believe that a total ankle and a simultaneous fusion of the subtalar joint cannot be done at the same sitting. Again, if done carefully, that's not true. It can be done. It's also sort of believed that methylmethacrylate, or so-called glue, which are used part of the time in the hip and knee arthroplasties, are not useful in the ankle. That's partly not true. It's not a very good idea, but it can be used when necessary, particularly in the much older patient with osteopenia. Another myth is that ankle replacement cannot be done with a history of ankle infection. Well, if the infection is remote and it wasn't very serious or into the bone, that's again not true. The final myth that we talk about, ankle replacement is precluded in ankles with significant varus or valgus. Well, that's not true either if you understand how to align and stabilize the foot at the same time or even before. The alleged gold standard or alternative to total ankle arthroplasty is ankle fusion. Now, we use that term gold standard somewhat loosely because even though it's the standard thing that we've always had to do, it isn't so golden. There's a relative contraindication to arthrodesis in young active patients in that it causes increased load in the other half of that universal joint, the so-called subtalar joint, and that will eventually cause it to become arthritic, overloaded and then arthritic. And the average of about 10 years, it'll show up on x-ray, and then of course, depending on the patient's tolerance for discomfort, it may be another 10 or more years before they finally come to having to have something done. Our protocol then, or a series of things about a protocol for ankle replacement. It's ideal in a patient with primarily ankle arthritis, either inflammatory or post-traumatic, and who has good overall alignment, age 60 or over, and without significant osteopenia. The people who are working on ankle replacement and trying to get it passed by the FDA will select these patients, and only those, to make their arthroplasty look good so that it'll pass muster. But it's not a very common presentation. People don't come with all those nice features asking for a replacement. They usually come with a variety of other things that make it difficult. Here's an example, though, of secondary degenerative arthritis from an old ankle sprain, which is, by the way, almost the most common cause of ankle arthritis, is a chronic unstable ankle from a sprain. This is an old college football player, now 64, has massive spurs and loose bodies around his ankle and degenerative arthritis, but primarily in the ankle, not so bad in the subtalar joint. And here's the result of a total ankle arthroplasty. The spurs and the arthritic braces are removed, and he's replaced with a total ankle replacement. The subtalar joint is debrided and everything is lined up. Next part of the protocol is an ankle replacement is an acceptable alternative in patients 45 and over who are well aligned, have a low impact lifestyle, good bone size to body weight ratio, and no osteopenia, and who understand that revision or additional surgery is inevitable. The point being that we don't have anything that's good enough if you're 45 to do to your ankle if it's badly arthritic that will last you the rest of your life. You have to buy into the fact that you will probably need 2, maybe 3 procedures over the course of your life to keep your ankle going. Example is a 50-year-old female veterinarian. She has an old injury with varus ankle and early arthritis of the subtalar and talonavicular joints already. So she would not be a good candidate for a fusion because the early arthritis in the adjacent joints below the talus would then become very symptomatic. So we have to do an operation that helps align her and then replace the ankle and take the stress off of the other 2 joints. Here's her intraoperative film showing the ankle replaced with the agility device and the fusion of the 2 bones, the syndesmosis above the ankle, which helps stabilize the upper part of the joint. It makes the operation a little bit more complex, but also more stable. And you can see that the subtalar joint has been a little bit debrided, as well as the talonavicular, and looks reasonably good now. And here she is 6 months post-operatively, back to work, relatively asymptomatic. Hopefully this will last her at least 10 or 15 years, but it may not, and she'll have to have another procedure, usually just a revision of this joint. It doesn't have to go on to a fusion, as we mentioned earlier. They have new equipment which can do a revision of this joint, even if it requires, and it may require by that time, fusing the joint below. Ankle arthroplasty in patients with major malalignment can be very effective in the hands of a surgeon skilled at realignment, especially if realignment is carried out in a preliminary operation. In revision cases with loss of the talus, secondary to loose components, previous or expected coincident subtalar fusion, significant osteopenia, or cases with primary loss of the subtalar joint, a custom stemmed talar component may be preferable and has been available now for 2 or 3 years. Here's an example. A 47-year-old man that had a childhood triple arthritis, in other words, an attempt to fuse and stabilize his foot because of muscle imbalance, but it wound up in severe supination. He went on about normal activities in spite of that, but eventually got severe arthritis in his ankle. You note that the joint below the ankle, the other half of this universal joint, is long gone, as well as a couple joints in front of that. The treatment then was to revise the triple arthrodesis to align it to the leg again. We had to take down the fusion and reposition it and fuse it to get it in the right alignment. And then you can go back and place a total ankle arthroplasty. And you can see, since there's no joint below that would be damaged by this stabilizing stem of the lower half of the arthroplasty, we can use that. And that gives this fairly active man in his late 40s a very good ankle back again. In patients with total ankle arthroplasty failure, where the reaction to the failure, which is usually from talar loosening, is hypertrophic bone with the formation of extra bone all around the ankle, a fusion is probably preferable to this revision by repeat arthroplasty. If the failure is due to component loosening or infection, but without bony overgrowth and stiffness, treatment is then best done by revision arthroplasty and can be very successful. Here's a 54-year-old man with hemochromatosis arthritis. He's 5 years after having an arthroplasty. Unfortunately, went on to gain a lot of weight, which is a bad thing for these joints, and pushed the lower half of the arthroplasty right down through the talus. And also you see that sort of cystic formation around the joint, which is from debris from the wear on the poly that's between the metal parts of the joint that gets in and causes granulation tissue to form around the joint. So he had 2 problems. One was collapse of the joint, and the other damage to the bone by the wear particles. Revision was done with a larger implant and by methylmethacrylate, and by removing, of course, the cystic tissue and grafting it or replacing it with methylmethacrylate and getting him back to a relatively normal ankle. And he had already realized that he needed to lose weight and begun on that. He will no doubt need to be revised again, probably by the stemmed arthroplasty that I just showed you previously. A final example, a single case exhibits several features and a protocol-driven solution with long-term follow-up. On the upper right, you see a woman who had had a severe fracture in her distal leg. She's a 50-year-old dietitian, moderately overweight, and has now a very bad problem with arthritis and malalignment, and not even complete union of her fractures. Now you can see in the lower left that we had done an osteotomy to realign the leg and put in smaller hardware, which then doesn't protect the bone so much and allows the character of the bone to restore itself. In other words, you get rid of some osteopenia. On the right then, you see that it's healed up in better alignment, and you can see it in the other plane as well. Now in good alignment and prepared well to do a total ankle arthroplasty, which we did now about 8 years ago. And this shows in surgery putting in the new ankle. On the lower left and the upper right, you see it at surgery, and it shows the pin that we put in the bone to hold the ankle in the right position as we put the ankle in place. And then on the lower two films, you can see it at 6-month follow-up, ready to begin normal activity. And then we see her at 5 years, and then at 7 years post-op. She's been back at work, doing her regular job without much of any symptoms for now, well, by now, about 8 years. After having been on crutches after her injury and without being able to use her leg for at least a year. Now, this is a tremendous preservation of not only quality of life, but being able to make her own living, and she's still teaching and doing all these things. She's probably got another year or so left on this one, and then with our new equipment, we can simply revise her and give her hopefully another 10 years, which will easily bring her past retirement age. This is a lot of what I would call bang for the medical care buck, in terms of the fact that this was not, it's a moderately expensive procedure, but if it gives you that many years of normal quality of life and being able to work, it seems well worthwhile. In summary then, ankle arthroplasty, or total ankle joint replacement, is an acceptable alternative in treatment of end-stage ankle arthritis when done with protocol-driven indications and appropriate associated procedures. It is, however, unpredictable, and even in the hands of somebody who is supposed to know very much what they're doing with a lot of experience, it has still got a ways to go to be a really predictable procedure.
So we've tried to answer a few questions patients ask, and one is just asking patients who've come here over the last 10 years what it is they can't do. We need to know what they can't do so we know how to gear our treatments in the future. And this is a very busy slide using the Musculoskeletal Functional Assessment tool, which is designed to measure the limitations patients sense in their function. And you see the highlighted areas that mobility, the higher the number, the worse the function. And you see that mobility for these patients is worse than controls. It's worse than patients who've had tibia fractures, and it's worse than patients with hip and knee arthritis. Fine motor is not as bad, but doing housework and working, these are really critical issues for these patients. The ankle actually returns about 50% more energy per step than the hip and knee does during running and fast walking. So when we asked all these patients what was wrong, the mobility question kept coming up and up and up, and it's mobility and recreational activities that restrict these patients over and over again. So we want to gear our treatment strategies toward getting them walking and getting them comfortable. And of course, outcome always depends on patient selection, and in this case, the position of the fusion, the state of the surrounding joints. As Dr. Hansen said, if you have a worn-out subtalar joint, there's no point in trying to do an ankle fusion because that next joint's just going to hurt. And when we think about functional outcome, we always have to think about what the alternatives are. As Dr. Hansen mentioned, if the alternative is a below-knee amputation, then there are risks that you can take to try to get function back because you know that your sequel, your alternative operation, isn't all that functional either. So there are some data to show us how ankle fusions do. In one study following patients from 2 to 22 years, about half of them, a little more than half of them, had no limitations. 66% in their own minds had had a good outcome. Now 66% is not bad, but it sure isn't great. If you told a patient there's a 1/3 chance their operation is not going to be doing very well in 5 years, a lot of people would turn around and head to the door. So it sounds like we need something better. There's another longer-term study published in Clinical Orthopedics a couple of years ago where they followed 48 patients for 9 years. 92% of them felt that they had a good or pretty good outcome, but when questioned, 47% of them actually had arthritic pain in the surrounding joints and limited the activity that they did because of the ankle. Saltzman's group had a very nice long-term study, and I'll summarize all this busy wording just by saying that the vast majority of patients after 9 to 15 years begin to have arthritis in the surrounding joints. So function matters and position matters. This is a very straightforward ankle arthrodesis. You can see the osteophytes all around the ankle joint and the bone-on-bone function with no cartilage at all left in the joint space. And these patients can do well because, as you can see, the position is relatively straightforward. An osteotomy is made in the fibula, and you align that talus with the long axis of the tibia, and this line marked by the arrow should be about 105 to 108 degrees. And as you can see, what Dr. Hansen pointed out before is this patient's a decent candidate for an arthrodesis because of this well-maintained joint space in the next joints along the trail. That's what it looks like at 6 months. They are splinted for 2 weeks, and an ACE wrap and a boot goes on at the end of that 2-week period. Return to weight bearing varies between 6 and 12 weeks depending on the diagnosis and the patient. The optimal position is a little bit of external rotation, a little bit of plantar flexion, and a little bit of valgus. It's not very common that we achieve that goal, though. In a lot of the studies, we find that less than half the patients are ideally positioned after an ankle fusion. In this nicely done study looking at function after ankle fusion, these individuals found that when the patients were fused in a good position, they walked well, but when the patients were fused in a position of plantar flexion, they had a very altered gait that affected not only their foot, but their knee and their hip and their spine as well. So 9 patients that were fused in a neutral position, in an ideal position, when they walked barefoot, heel rise occurred early. There was less knee flexion and more posterior ground reaction force. But when they walked in shoes, nobody could really tell. Now, if they come to you in a bad position or badly fused, it's possible to salvage these by cutting some fibula. You can see this patient is missing the fibula. Had been taken off at the time of the prior 2 ankle fusions that did not succeed. And you can actually cut this fibula and bring it down and use it to stabilize the foot in a good position. And this patient went on to uneventful healing. This removed fibula idea is fairly popular, as you can see, and it's not an uncommon circumstance to have to go up there and grab some of that fibula and bring it down. But they do heal, and they do have function similar to a primary ankle fusion. So we talked about position and its impact on function. This is a slide given to me by Andy Sands, who he got from a colleague in Europe. And this is a patient who had long-term follow-up, 5 years post-op. You can see how much compensatory show parts motion there is in the plantar flexion and dorsiflexion views. This is a patient of mine who had bilateral ankle arthritis. He was only 48. He had had both of his hips and both of his knees replaced already. Just click on it. And when I was talking to him about ankle replacement, he said, why would I want to have anything but an ankle arthrodesis? And this is what his foot was doing. Now, it looks like a lot of motion, but if you look at the hind foot, there's very little motion in the hind foot. It's all through show parts joint and the subtalar joint. This is another patient who was 7 years out from an ankle arthrodesis. And I'm not going to tell you which side is fused and which side isn't fused. Try and guess for me. As you can see, she can walk very normally on a flat surface with shoes. It's only when she's walking barefoot or on an inclined surface that you can assess the changes in gait. So we try to compare this to total ankle arthroplasty. It's very difficult to do because the data are all over the place. But a meta-analysis done of 18 studies of ankle arthroplasty showed that the superficial infection rate is about 10%, the deep infection rate is about 1.6%, loosening occurs about 5% of the time, there are intraoperative problems with dislocation and fracture, and about 12.5% of them need to be revised. So again, this is not terrible, it's not great, it would be nice if we could do better, but we really don't have a good idea of what better is. So the summary for ankle fusion is that it works well if it's done right. Gait is normal when wearing a shoe and walking on a flat surface. The quality of life declines in the long term due to increasing arthritis in the other joints, but we don't know what the better alternatives are. So for a few patients, they'll fall into a zone where neither ankle arthroplasty or ankle arthrodesis is good. And for those, there are some what we would have to call experimental operations, like taking cadaver bone and putting it into the ankle joint. There are a few studies with small numbers of patients finding about a 60% success rate. Again, not at all a very good success rate, but maybe better than the alternative. This is a patient of mine from 1992 who was only 29 years old, and as Dr. Hansen mentioned, body weight to bone size ratio, this woman was about 5'4" and probably well over 250 pounds. Not an ideal candidate for replacement, not an ideal candidate for an arthrodesis. So we used some cadaver bone, replaced part of her talus and part of her plafond, and this is what she looked like during surgery. This is what she looked like at the end. And here she is a year later. It's not a normal joint, but at least the foot is straightened out. It belongs under the tibia where it belongs. And she lasted only about 7 years on this before I had to take her to the next step and do an arthrodesis. The last piece of the armamentarium, Dr. Hansen covered a little bit already. If the bone's not lined up, you can line it up. And just lining them up sometimes will take away the ankle pain. So this is a patient who was quite deformed 25 years after a tibia fracture. I had planned to straighten her out and then do a replacement. This is what she looked like immediately after surgery. This is what she looked like 6 months after surgery. And she decided not to continue with further treatment because just straightening out her ankle had relieved her symptoms to such an extent that she didn't think she needed anything more. So when the patient asks what's best for her or him, it's a tough question to answer. We've done a couple things to try to help us get data to answer this question for the patients and for the doctors. So we strapped some activity monitors on a group of patients who had had a successful ankle arthroplasty and a successful ankle arthrodesis. We let them do whatever they wanted, and we had them keep a daily journal and a log and assess their functional outcome. And we actually counted the number of steps they took per hour, per day, per minute over that 14-day period. And we thought we'd get some wonderful information to share with the patients. And we learned a few things, that all the patients were very active, whether they had an ankle arthrodesis or an ankle replacement. About half of them reported activity limitations, and it was primarily in sporting activities, not in the things they do from day to day and the things that they do in the workplace. But we found no difference in this activity level between those that had a replacement and those that had a fusion. This is just a small pilot study. It's part of a 3-year ongoing process where we're going to try to figure out what works best for individual patients. Okay, that's the end of our grand rounds for today. Thank you very much for coming.